Hello, welcome back to EASD TV. Now, one of the most important features of the EASD Congress is the session where there is a collaboration with another organisation. We've seen it in diabetes and nephrology, but also very importantly with cardiology. And there was a session this morning, the ESC Symposium on new perspectives on heart function and failure in diabetes. Francesco, you were the chair of this session today. Perhaps you'd introduce yourself and then introduce us to the participants in this symposium.
Yeah, with pleasure. I am Francesco Cosentino, cardiologist, working at the Karolinska Institute, Karolinska University Hospital here in Sweden. And I think it's very important, this session, a joint session between the ESC and the ESD on this topic, heart failure, because what we have learned from recent advancement is the necessity to have a very tight collaboration across a specialty border to reduce the burden of our patients with diabetes.
And introduce your compatriots here.
Yes, well, it is a pleasure for me to introduce the co-chair of the session, Professor Allan Vaag, from the Steno Diabetes Center in Copenhagen, and then my colleague and friend Lars Lund, Professor of Cardiology here in Stockholm at the Karolinska Institute, Karolinska University Hospital, and Nikolaus Marx, Professor of Cardiology and Internal Medicine at the University Hospital in Aachen, Germany.
So we've got an equal disposition here of cardiologists and endocrinologists. Nikolaus, let's come to you. Of course, it is the really the diabetologist who sees patients with potential heart failure much more often than the cardiologist. So they are in a position to take effective action, aren't they?
Absolutely. I think the most important part is to recognize if a patient might have heart failure. And it is important to evaluate a patient with diabetes for that, asking for symptoms, shortness of breath, fatigue, something like that. And if this is the case, the next step would be a lab test for NT-proBNP. And if NT-proBNP is elevated, it could be heart failure, and then the patient needs to refer to us, to the cardiologist, for an echo to assess ejection fraction and other functions. But the diabetologist is the kind of gatekeeper. He needs to assess the patient by symptoms, the test, and then go on. Very important.
And there are drugs available. We've had a trial reported here, that these drugs are available and can be started quite quickly.
Absolutely. For example, 7 years ago, in particular at this meeting, the first trial, Emperor Reg Outcome, was presented. So we have SGLT2 inhibitors, we have GLP-1 receptor agonists, and these drugs reduce cardiovascular events, but with respect to heart failure, in particular SGLT2 inhibitors have been shown to improve cardiovascular morbidity and mortality.
Let's hear from a cardiologist then.
Yes, so indeed, it's very important to understand the close link between endocrinology and cardiology. And in the case discussed this morning, the specific link between type 2 diabetes and heart failure. It's actually specifically so that type 2 diabetes is a huge risk factor for heart failure. It causes heart failure. There are mechanisms described by which diabetes causes heart failure. In particular, this emerging type of heart failure when the ejection fraction is normal, or heart failure with preserved ejection fraction. And this category of heart failure is so closely linked to diabetes in the pathophysiology, the mechanisms, and now also in the treatment, because heart failure with a reduced ejection fraction, typically caused by cardiomyopathy or a myocardial infarction, has many treatments. Heart failure with preserved ejection fraction, when ejection fraction is normal, has one treatment, SGLT2 inhibitors. So this opens the door for understanding all aspects of the interaction between diabetes and heart failure, and we're only at the beginning.
You're the endocrinologist aside, so what did you take from this morning's symposium?
I come from an era, being an endocrinologist for more than 30 years, where we have been increasingly concerned about glucose-lowering drugs, that they did not prevent what is really important diabetes, namely patient-relevant outcomes with respect to cardiovascular disease and also renal disease. In that sense, glucose is the biomarker that defines type 2 diabetes, and it has been previously a frustration that the drugs we used, including insulin, did not really translate into benefits in the heart. And that is why the EMPEREX study 7 years ago with the SGLT2 inhibitors really nailing that this drug was designed to reduce glucose, that also had significant benefits on the heart and the kidney. And now afterwards we have learned that this drug type also prevents events in non-diabetes patients, both with respect to the heart and to the kidney. That has been a fantastic evolution to be part of in the field of endocrinology, and has really nailed the conclusion also now mentioned by the cardiologists here, that we need to work more together. There are crosstalk between diseases. We see each other diagnoses. We need to be aware of heart failure in the diabetes clinics and vice versa of diabetes in the cardiology clinic. I think that is the essence. And even though it's 7 years ago this discovery was made, we haven't implemented the full kind of learnings from that yet in the clinic. So this is the journey we are in right now.
So we are possibly still in a situation where there are silos, cardiology, endocrinology, rather than having the integrated care model that we need for this particular group of patients.
That's absolutely so. And I can say at the Steno Diabetes Center, where I'm partly affiliated, I'm also affiliated with Lund University in Sweden, we have just appointed a cardiologist as the CEO of the clinic, actually, not only because this person's leadership but also skills, but also because we want to move in that direction in endocrinology.
Francesco.
I would like to add that despite all this positive attitude that my colleagues have explained to you of the importance of a collaboration, we have to remind our audience that the implementation of very effective treatments for the therapy of patients with heart failure and diabetes remains very poor still today. So we need extra effort to convey the message that we have very powerful drugs which may have an impact on the morbidity and mortality of our patients with diabetes and concomitant morbid conditions such as heart failure or kidney disease. And the implementation of this treatment has definitely to improve across Europe and worldwide.
Would you like to add to that?
Well, I think Francesco's right. If you look at the data, I think only a small percentage of patients with diabetes and cardiovascular disease receives these drugs. It's a matter
Which actually can be started in primary care, I think.
I think, of course, if the diagnosis is made, no, let's put it the other way around. If the diagnosis of diabetes is made and the patient has cardiovascular disease, it can be started in primary care. But with respect to heart failure, it's important to assess what kind of heart failure is it. So I'm not saying that every patient who has shortness of breath and antipropium should receive this drug. He needs to see a cardiologist, he needs to see us to get an echo and to assess the reason for the shortness of breath and then go on. But it's important that the treatment is continued.
And the big message is that the diabetologist should be alert for the symptoms of heart failure.
Absolutely.
And perhaps they're not being as alert as they should be.
But I think, if I may, I think this time now can be an eye-opener for both fields, because traditionally we've considered heart failure what's called a neurohormonal disease with activation of the neurohormonal system, and we've considered the interaction between diabetes and cardiology mainly from a vascular perspective, the risk of myocardial infarction. So this is eye-opening now that we're learning that heart failure is a metabolic disease. Heart failure is a metabolic disease driven by type 2 diabetes. And from both ends of this spectrum, if we understand that, not only will the collaboration be better, but future development, discovery will be improved also. SGLT2 inhibitors are only the first step in the metabolic inflammatory paradigm of heart failure, and the doors are now wide open with many of the agents used for multiple syndromes, type 2 diabetes, obesity alone, NASH, and HFpEF. These belong together.
That's a very ringing endorsement, Lars, and we're going to end there. Thank you so much, all of you. And I think you can hear very loudly the need for diabetologists and for cardiologists to work together much more effectively for the future, for those people living with diabetes who it's clear are being treated suboptimally at the moment. We'll have more for you soon. Back in a moment.